okay.
You're the
Um,
head of the department now, huh?
I know, right? How things
Amazing.
could, yeah, it's amazing. Um, well, the program has not closed yet, so I haven't destroyed anything.
Right, you really haven't.
Yeah, so I must be doing something not crazy.
Yeah, right.
Yeah, yeah.
Is
Um,
Kim still there, or is she
yeah,
gone?
she is. But she's in a different role. She is the director of the Interprofessional Education Center. So the
Okay.
IPE Center, and you might recall this, when we were just trying to do some interprofessional activities with the
Right, yeah.
PTs. So that's like the precursor to it. And then now that the School of Nursing, the School of Medicine are their own independent entities, um, we got together and then put up a center. And
Nice.
yeah, so that's nice. And for a while, how I got roped into this job is um, Kim was the
No one
interim.
else wanted it.
I know, number one. It's like, you crazy? The other is, yeah, Kim was for a while the interim dean.
Right, I remember that. I think that
Yeah.
happened like right when I left. Or...
Yeah, yeah, because it was still Ed O'Connor, right? Who was the
I
dean at
think
that?
so.
Yeah, yeah.
Actually, she might have been the interim dean when I was a grad student.
Oh, I see.
I think I don't remember. I think
Yeah.
so.
Okay, all right.
I think that's when she went.
All right. Well, uh, I saw like a couple of your, pictures from a couple of your cohort. Like with Kathleen getting married, and
Oh, yeah, yeah.
yeah, I saw
Everyone's
some.
getting married, so.
I know. Like, when is your
Our
turn?
whole crew is married.
Yeah, yeah. Well, life happens.
It does.
Yeah.
Uh,
So anyway, do you have any questions regarding the actual study before we begin?
I don't think so. I'm not 100% sure I know what you're going to ask me, but let's do it.
Let's go for it, right?
Yeah.
Okay, so first, tell me, when was your graduation date, your official graduation date?
January 2014, I graduated from grad school.
Okay, January 2014.
I believe it was January 15th.
Yeah,
2014.
That's right, that's right. And so tell me your current practice. Where do you work? What's your title?
I currently am an OT for the Department of Mental Health, and I work at the Worcester Recovery Center and Hospital, which is Worcester State Hospital, so inpatient psychiatric.
Wow.
Yeah.
You like mental health.
I love it.
I love it too.
The best.
Yeah, yeah. So how did you get hired into this job?
So my first job out of college, I worked in this exact hospital building for a company called New England Family Institute, and they run the 2 adolescent units in the hospital under an intensive, it's like intensive residential treatment program, so it's called an IRTP. So technically it's not a hospital level of care, but it is a locked intensive treatment program, and it's in the hospital.
I see.
So I just had connections with various people that had worked there and knew that they were hiring. They were in the process of moving into this building and took a contract from UMass, so they were hiring, and under the contract that they signed, they had to have a full-time OT, which they hadn't previously had. So I'd come in that way to the hospital, and then I worked there for about 2 years. I loved what I did, but it was really draining.
Yeah, yeah.
And very sad, and kids were really just had horrible stories, and it was kind of consuming my life, and I would come in all the time, and I just knew that I needed to, make a change. So I applied to the adult side of the hospital, which is directly run by the Department of Mental Health, whereas NFI was funded by the Department of Mental Health. And I didn't ever hear back. So I ended up leaving NFI, and I went to Fairlawn Rehab, which was a cute biz, and I hated it. I hated the minute of it. I cried every day. I also just think it was different, too.
Yeah.
But I was there for probably 33 days, and I got a phone call from the director of rehab here, where I am currently, saying, you applied for this job a couple months ago. Are you still interested? And that's how I kind of came here.
Nice.
I've been here 2 years in November. I will have been here.
Oh, wow. How is it? How is it out there?
How is it out? How do I like it?
Yeah.
How does it compare?
Yeah.
The adult side is, I think from a system standpoint, the Department of Mental Health owning the hospital, it just runs so much smoother. It's better funded than NFI was. Mm-hmm. There's more structure just because it's a state agency. Yeah. So I like that aspect because NFI did have it kind of like a mom and pop type operation to it, so things were a little bit more disorganized.
Yeah.
And I love the adult population. We actually have a really diverse population where we have, our long-term mentally ill patients, schizophrenia, bipolar, and then our hospital is actually really slowly, or it feels quickly, transitioning to a forensic population.
Oh, wow.
So we have 2 sole units in our hospital designated to forensic evaluations for competency to stand trial and things like that. They're typically 30-day admissions. I don't work on that unit.
Yeah.
I work on a continuing care unit, but we still see a lot of forensic patients, a lot of step-downs from the Department of Corrections.
I see.
And things like that. So
wow.
Kind of a good mix of more long-term patients and then more transitioning patients back into the community.
I see. And are you the only OT there?
I am not. So the way it works is an OT carries a caseload of 26 patients. So you're assigned to a unit, and there are 10 units on the hospital. Mm-hmm. So we have 10. Well, I don't think we're fully staffed right now, but theoretically we're supposed to have 10 OT, what they're called OT1s.
Yep.
And then we have 6 OT supervisors. And then we have a director of rehab, who happens to be an occupational therapist.
Nice, very nice.
Mm-hmm.
And how closely do you work with the non-OT professionals?
More closely than I work with the OTs.
Oh, wow.
So yeah.
Yeah.
So how it works is that every unit has 26 beds.
Yeah.
So you have 26 patients. The OT is responsible for the whole unit.
Yeah.
So they have all 26 patients. And then on your unit, you typically have 2 social workers, maybe 2.5, I would say, assigned to those 26 patients. Probably 2.5 psychiatrists, 1.5 psychologists, and then the nursing staff, rehab staff who are rehab counselors, and they do a lot of groups.
Yeah.
And then MHW staff, which is kind of the line staff.
Mm-hmm.
So every day when I go to rounds, I don't see any other OT. I mean, I'm in rounds with my doctors, my nurses, my social workers.
I see.
So in a day, besides OT meeting, which is once a month, there isn't too much. I do run one group with an OT, but that's not going to last forever just because they want to divide their resources and, have 2 OTs running groups instead of 2 OTs running one group,
I see.
So not often.
Not often. I see. But do you get to at least have meetings with your other OT contemporaries, or?
Yeah, we have, now they're weekly OT meetings because our hospital is kind of going through a revitalization, so things are changing. So we used to meet monthly, now we meet weekly. I share an office with an OT who Her unit is on the same floor as mine.
Mm-hmm.
So in groups, the groups are hospital-wide. So I have 26 patients on my unit, but when I run my groups, I could have anyone in the hospital, theoretically.
Yeah, yeah.
So there is a lot of, sharing between OTs. Like, this is what happened with your patient in group today, or this is what I observed.
I see.
So, yeah.
Amazing.
That does happen.
Yeah. So, well, thank you for sharing that. So now I wanted to talk to you about kind of like, I know you got yourself into a mental health psychosocial area of practice. And so I want to go back to the time when you did your OT 500 field work, which is our psychosocial mental health field work. Can you tell me about that experience?
Yeah, so that was my first field work, and I was placed right across the street from where I am at UMass Memorial, I think it's UMass Memorial Hospital.
Yeah.
And I worked on 8 East, which is their acute psychiatric unit. So I think they were 28 beds, and they recently just got cut to 20, I think. I'm not 100% sure how many beds they were. But we did acute admissions. So they were 2 to 3 days, and then people were discharged mainly back to the street. It was just kind of like a stabilization, evaluation, and then discharge. So in that setting, our assessments were more screens, and we were doing a lot of groups, 6 groups a day.
Yeah.
And it was really quick. And people were in and out.
And were you with other students?
Yeah, I had, going in the Wayback Machine, I think I was with one other student who was from Worcester State.
I see. And and so then how did you work with them, or did you directly work with them?
Yeah, we did. So we ran a lot of groups together. We kind of rotated on admission, so we were constantly in communication with each other in terms of, because with the acute admissions it was quick, so we would always kind of have to coordinate it based on admissions. We divided the units, so took half and half, and then went to the respective teams. I think our running groups together, planning groups together was our biggest kind of shared responsibility.
I see. And how about supervision? Were you supervised by both OTs and non-OTs?
No, so I was only supervised when I was at that field work. There were 2 full-time OTRs, 1 full-time CODA, and a half-time OT. So I was supervised by a full-time OTR, and the other student was supervised by the other full-time OTR.
I see. All right. And so overall, what do you think about your experience?
I think it's why I'm doing what I'm doing, and out of all of my field work, I think it was the most important one that I had.
Wow. So kind of, did you have any kind of a different impression when you started your field work about what mental health was like?
Yeah, I didn't want to do it.
You didn't really like it?
Well, I didn't. I was like, what? Why do we have to do this? I was never, ever, ever thought, besides loving Ro and Lou, I never had any inkling that I would end up in mental health. Never.
So
I loved them. I loved their class, but I was just like, I'm probably not going to do this. And then that was my first field work, and I absolutely loved it. I had 2 other really great fieldwork experiences. I worked in an outpatient ortho, and I worked in a sensory integration clinic in New York. I loved them, but my psychosocial was, when I was done all 3, I knew I wanted to be in mental health.
So what do you think led you to that direction?
I just think that it is, I felt like it was the most challenging field work for me because, in the outpatient, I worked in like an outpatient sports rehab clinic, and we did a lot of like hand therapy and elbow, shoulder rehab, things like that. And I just remember feeling like I had to memorize these protocols for frozen shoulder, and I had to memorize the, nerve intervention, and I had to memorize nerve glides and all these things. And then in sensory, I had to memorize the order of input and, all these things. But with mental health, I felt like no matter how much I knew, it never really helped me in the moment. And I had to really develop my clinical reasoning skills and stay on my toes. And what you learn in school is helpful, but you really develop like an ability to work with all sorts of people. You're always having to think outside the box.
Yeah.
You're always having to think about the whole person. You have to think about, their physical limitations, their cognitive limitations, their goals, their barriers. I don't know. To me, it wasn't as linear as all the other areas, and I liked that challenge of trying to have to figure out, what am I actually going to do with this person?
I see. And
And
it does not have anything to do with the diagnosis?
What do you mean?
Like, because you said, earlier you were, it doesn't, or at least maybe, if I heard you correctly, that you could work with practically anyone.
From that experience, I felt comfortable working with any type of person.
Yeah.
Just because when, especially in the state hospital, people are very violent, very psychotic, very ill, very difficult, very resistant.
Yeah.
So if you can engage that type of patient, going to a nursing home or going to an outpatient clinic, difficult patients won't really compare, and it will feel like I always felt like it was very easy. Once I had my first placement in mental health, my other two field works, dealing with people just on a therapeutic level was much, much easier, because I kind of felt like if I could deal with the types of people I was dealing with, I could kind of deal with anyone.
Yeah, so I think that's pretty good. How about in working with non-OT staff while your field work? Was there any? How was that like, by the way?
It was a couple of years ago, so I do remember working very closely with nursing. Nursing would help, get patients to groups and things like that. And then the biggest part of what I remember is in teams, doctors, because, like I said, people were in and out in 2 days. Doctors were really looking at OT to kind of step up and say, can this person, does this person need to go to a group home? Can they go back to living on their own? What do they need? And that was a very prominent theme, and kind of all of our discharges was doctors coming to us asking, what are their abilities? Where are they at functionally? So the ACL was a big part of what I did, and using that to determine discharge plans. I honestly don't really remember working with social work in that field work. But I know that they were there. I just don't really remember it being as big of a role as it is where I currently am, which social workers and OTs work very closely together here.
I see. In your
my current job.
In your current job, but in your previous job, in your field work, you primarily had more interaction with nursing and with the psychiatrists.
Doctors. Yeah. I don't really remember.
Yeah.
Too much.
That's okay, and so, but at least from what you can remember, was there any change in the way you perceive them going into your field work compared to after you finished your field work?
Perceived social work?
Yeah, no, the nursing, the nurses and the physicians. So you may have some ideas of what they do in that setting, and then has that perception did that perception change?
No, I don't think so. I think they were, I don't know what, I can't tell you what I was expecting them to be, but I think it very much felt clear that what their role was and how it worked with what I was doing and how it was different.
Yeah.
So
I see.
I don't remember really being surprised by that.
So overall, if you could think of your top 3 things that you feel you learned from this fieldwork experience, what would those be?
Therapeutic use of self, definitely. I would say it was the biggest it challenged me the most with my clinical reasoning. Therapeutic use of self, clinical reasoning. And I would also say, I don't know, the 3 biggest things. I don't really know if this matters, but I was thinking it really challenged me to learn and to develop my ability to assess the whole person. Truly.
Wow.
From volition to motivation to what they're interested in, to their physical barriers, to their cognitive barriers. It just really challenged me to think about every aspect
I see.
of somebody and assess that.
Wow. So if you were, do you think that if you were not placed in this site, would you learn the same things in other psychosocial settings?
In other psychosocial settings?
Yeah.
I would imagine that you would learn those things in other settings. Yeah.
So it's kind of like there's nothing, anything particular about this site that you were at that led you to...
No, I think it was more about the patient population. I don't think it was specific to the site. So I think anywhere that you were kind of... the acuity certainly. But yeah, I think just the psychiatric population really challenged me to develop those 3 things.
Yeah.
The site was excellent and obviously fostered that. I don't necessarily know if you would really develop your skills in a group home or a community-based psych setting, but a hospital-based psych setting, I really think so I guess maybe hospital is what really made it intense. And
So,
I'm not really sure if I would have developed those skills in the community psych setting.
I see.
I would probably imagine I might not, actually.
Because of the population that you were working with?
Yeah, just the acuity of the people that I work with.
Yeah. So it sounds like a lot of the, if I'm hearing you correctly, that a lot of what you've learned in this fieldwork site actually influenced the way you're working right now. Is that not accurate? Yeah. And then does that apply to working with not just only clients but also with your other professionals?
Yeah.
Yeah.
Absolutely.
Yeah. I guess overall, in thinking about, and you may have already mentioned this, but I want to get your perspective on this one. So, compared to your non-psychosocial experiences, do you feel that your psychosocial fieldwork had more or less of an impact on your current beliefs about the profession?
I think my psychosocial had the most impact on our profession and my beliefs. And
what do you think is that belief that, wow, this is what OT is all about? What was that about the psychosocial fieldwork?
I think in every other placement I was at, I really felt like I needed to know what their diagnosis was. So when someone walked into an outpatient clinic, I needed to know that they had trigger finger. In sensory integration, you needed to know that the kid was hyper-aroused or you needed to know. And I think in psychosocial, it almost doesn't matter if they're schizophrenia or schizoaffective or bipolar. It just, you have to meet the person where they're at and kind of develop an intervention that fits based on that. So it's more about looking at the person and figuring out, what are they able to do? What are their barriers? What do they need help with? And that you just kind of get from knowing them and talking to them.
Yeah.
So I kind of felt like we always are taught that people aren't their diagnosis. And in psych, I really believe that because I don't need a diagnosis to do an assessment. I can just go in and talk to a person and kind of look at their thought process and their ability to organize. And it just doesn't, obviously I know it. And obviously, PTSD and trauma considerations are important and you have to know that, but it's not like if someone comes to me with schizophrenia, I have to do X, Y, and Z.
Right.
Which I felt like when someone came to me with trigger finger, I had to do X, Y, and Z. So it just really challenged me to look at the whole person, and I think that was kind of like my OT moment. I was like, oh, this is what we do. This is why we're different.
Yeah. Wow, that's
at least for me.
Yeah, no, I think that's it makes me smile actually to hear that. Are there any things that that you'd like to share with us that we didn't touch upon yet? So far, you asked me earlier. You don't know what kind of questions I'll be asking, but pretty much we're at the tail end of our interview. But are there certain things that you thought or you think that we wanted to, or that you want us to know, or?
Yeah, I think so I actually saw Pam probably 3 or 4 months ago at a fieldwork educator seminar in Worcester, and I've been taking students for the past year, and I actually had sent her an email a couple days, ironically, before I saw her, saying, I haven't gotten any Quinnipiac students. What's going on? And she kind of mentioned to me that perhaps it won't be a requirement and that they're having a hard time and that maybe, I think I heard that something new is happening where they all have to live in Connecticut, or I don't really know. So I guess I'm curious, like, what is happening and what is the rationale for having this interview, and what are you guys, looking at?
Yeah. Well, part of it is just to look at what effect that students' fieldwork experience may have had in mental health in their current practice, because it's very difficult to assess our outcomes based on an interview immediately after graduation. It's really more down the road. What is it really that that makes our students do whatever they do now, or our alums, and the decisions that they've made, and what influenced them, etc., and how important it is for them to have a mental health psychosocial fieldwork. And we still do have a requirement, the mental health and psychosocial fieldwork, except that now we have to cut it short to 6 weeks rather than the entire 12 weeks. For the simple fact that I think your class was in the 50s, right? There were about 50
Yeah, I think we graduated at 54, maybe.
Yeah, and then the other classes that followed you were, upwards in the tune of 75, and then we're going to get the 90s.
Wow.
Yeah, and it really challenged us. There were a couple of consecutive years where we could not place students in mental health psychosocial, and so we had to start placing them in PhysDis before the psychosocial. And it was really not good in terms of our curriculum design. Now, were you in the same class as Jackie Corcoran?
No, she was.
She was a year. She was a year ahead. No.
Her name's familiar, but she wasn't in my class.
Yeah. Who's the guy in your class?
Joel.
Joel,
Cole.
I see. Okay, so Joel.
That's how you remember classes, Sal, isn't
I
it?
know, like I know that you're in the same class as Marilyn and
Mhm.
Danielle, right?
Yep.
Um, um,
Joel, Cole, Ryan.
yeah.
That was my class.
I haven't. Like, Cole is nowhere to be found.
Cole actually teaches, Sal.
Really?
it's
What?
it's very shocking. He teaches at Hofstra. He teaches a lab, I think.
I am.
I
My
actually
mind is blown.
I know, right?
Yeah.
Out of all the I still talk to Alyssa,
Mm-hmm.
Zach,
Silverzan.
Mary Lynn.
Yeah. Yeah.
But Cole is like my best friend still.
Oh.
Yeah. Yeah.
Wow. Wow.
So he actually teaches and he works at a school.
I see.
Mhm.
How things turn out to be, right?
Yeah.
Yeah, and yeah, kind of. We did kind of try to make our our curriculum still work and not lose that mental health psychosocial.
Yeah, I would
Um,
be very sad
yeah,
if we did.
and
'Cause,
yeah.
I mean, obviously I'm biased because this is where I am, but I
Mm-hmm.
do think
Yeah.
I wouldn't be here without that.
Yeah. I don't know if you know Dennis Apteker. He's an he was a mental health OT at EL Psych.
No, I don't.
Yeah, he's now one of the fieldwork people. So we brought him in, and now we're bringing students to Yale Psych as kind of like a quasi fieldwork one,
Mhm.
and also at Solnet up in Waterbury, um, like getting them immersed, and then we now have a mental health one and a mental health two course.
Oh,
Um,
nice.
yeah, so it used to be a like in your class, you had Lou and Lou in the first semester. I mean, like in the fall
Right.
semester, and then there's the groups class in the second semester, right? Where you
Yeah.
did your protocols, and so we reshuffled the curriculum. So now there's mental health one
Oh, nice.
in the it's focusing more on children and youth, so adolescent issues and all the diagnosis that comes along with that. And
Oh,
then
good.
the adult is in the second half, in the second semester,
Yeah.
like in the spring. So
Oh, that's
yeah,
nice.
it's still a very strong aspect of our curriculum. It's just that
Good.
we have to make sure that our field work is that we can deliver the field work, and we kind of got some flack from the Connecticut OT mental health people, thinking that
Yeah.
we're abandoning mental health. And it's like, no, we're not. We're actually trying to make sure that all students will get the same if not similar experience, any kind of mental health and psychosocial practice, whether it's community, whether it's inpatient, acute,
Right.
most of
So,
it, yeah. Go ahead.
so are all your placements going to be based in Connecticut?
They are right now, but we're open to expanding. If you are interested.
I
Ah!
am. I don't even know. It was a new lady. Her
Lisa.
name,
Lisa.
yes, Lisa.
Mm-hmm.
Because I had emailed Ro and I was like, I will take, I mean, so our student, we have so many OTs and unfortunately we don't have the student program that we should have.
Mm-hmm.
And that's actually one of my professional goals is to kind of get us up to speed and have students here more regularly.
Yeah.
So I told them I'm willing and able, and I want to figure out a way to have Quinnipiac kids here. But then I kind of had heard that they might not have them because they're going to be in Connecticut. But then I think Pam told me that they could still choose their third one.
Yeah.
As the mental health.
Mm-hmm. Mm-hmm.
So maybe that will be
yeah.
a way in for now.
Yeah, and we have a couple of them who did a almost like a double mental health affair. So they have the 6 weeks here in Connecticut and then another 12 weeks elsewhere. The only reason why we kept them all here in Connecticut, the 6 weeks and 6 weeks, is so that we can train the instructors, because a lot of
Mhm.
them are community based. There's a few that are at CVH, um, and at Middlesex Psychiatric. Um,
Okay.
yeah, but very not all of them are in. I mean, there's not that many acute or inpatient stuff. Um,
Mhm.
but I think we're probably at the point where we can start looking at going into the outside of Connecticut. Because
Good.
there was one time where we would send 3 or 4 students to Suffolk Hospital, um,
Mhm.
and and now they said they're only gonna take students from Long Island.
Oh,
And
yeah.
then Greystone, we had
Mhm.
8 students ready to go to Greystone, and then suddenly, the governor closed the OT unit
Mhm.
4 weeks before
Yeah.
it
I
was
remember
all.
that happened to Alyssa too, because Alyssa is from Massachusetts like me, and she was supposed to have her psychosocial at Taunton State,
Mm,
and Taunton State was closing. So like a week before her placement, they ended up backing out of her.
mm-hmm.
But then, ironically enough, Taunton State never closed.
Wow.
So Taunton State
Yeah.
still open. But yeah,
It's crazy. It's crazy, but
yeah,
we're keeping it alive, and I
good.
appreciate the email to Lisa, and I think now that you and I are talking right now, it's like it's making me think to look into venturing out some more. So yeah,
Yes,
yeah,
and I would love to be involved and be helpful in
absolutely.
any way possible because I think it's an important thing.
Hmm. Well, come and visit us one of these days.
I will. I
Yeah.
will. I have to.
Yeah, and I don't know how since you left, whether you've seen the new buildings. Yeah,
I think I don't know how. It feels like there's always new buildings,
yeah.
but I had gone back probably 3 years ago. Was
Mhm.
the last time that I had been there.
I see. Yeah, yeah.
So it's probably a whole new world.
It is. It is. So
Yeah,
yeah, uh,
I'll have to come see it.
absolutely. Well, well, thank you so much for the time, and I really
You're welcome.
appreciate your enthusiasm and support for mental health. And
Yes.
um, yeah, even though I'm actually, my first love is mental health.
Yeah.
I just got traumatized by it. Yeah. Yeah, and then like the the OT world brought me to a different direction, but I
Yeah.
always feel that mental health lives in me. So yeah,
Yeah. I think it's
yeah,
It's in every other aspect of what you do.
exactly, exactly.
So